Can you see my screen?
No.
No.
Not.
No?
No.
How about now?
Yes.
Okay, all right. So let's go to CKD now. Now, this is the boring part of the of the disease because unlike AKI, wherein the changes were dramatic and they occurred within hours. So, for instance, let's say me and Davian are going out, and then one day Davian wakes up and says, "Oh, I can do better than Mr. Escarda." So she goes out and she dumps me and then she goes out to have surgery. So let's say she has a couple enhancing surgeries, aside from the facelift. So she had all these several things done. So when she went before surgery, she was a healthy person. But then when she came out of surgery, because she was exposed to blood loss, she was exposed to IV dyes maybe, or maybe too many medications. So she experienced AKI. So she went from being a healthy person at 9 a.m. and then when she came out of surgery 3 hours later, now she has AKI. Okay, so those were very dramatic changes that happen. In CKD, no such thing occurs. So we're talking about a diabetic here, a hypertensive patient, or a heart failure patient. What are the other risk factors here? Um, so here, hypertension, diabetes, lupus patients, patients born with polycystic kidney disease, or those who had been admitted for a kidney infection, acute kidney infection. So here the changes occurred over time. Okay, the patients weren't even aware that this is going on, but one thing we know is whatever chronic condition they haven't been managing it very well. So one day, little by little, especially if they don't um, visit their doctor often or they don't comply with the regular appointments. So the doctor may go from, let's say, last year was your last visit. This was your beyond creatinine at that time. So now, 18 months later, you show up to your doctor because now you're feeling weak. And then when the doctor looks at your labs, oh, look at this. Last year it was like this. So now, almost 2 years later, look at your BN creatinine now. So you're experiencing um, organ damage from number one, your hypertension, from your diabetes, or from, as stated here, from your lupus, etc. And then, so this is now where the stages is now coming in. So there is no phases in CKD. It does have stages indicating severity of the kidney disease. So we use the rifle classification. Rifle as in the rifle, the weapon, okay, the gun. So the RIFLE. So that represents the 5 stages of ESRD or CKD. I don't know if they have the rifle here. No, no rifle. Anyway, rifle classification stands for R is risk, I stands for injury, then F stands for failure, and L is loss of kidney function already, and then E, of course, is the end stage. So that's the 5 stages of chronic kidney disease. Once
Professor,
you're
can you
at
repeat that for me, please?
a rifle, um, R meaning you have the risk, I is now injury, L is no F first, F is failure, L is loss of kidney function already, then we have E is end stage. So those are the 5 stages. With the rifle comes a range of your GFR. GFR, of course, is your glomerular filtration rate. Now, why didn't we do GFR in acute kidney injury? Why is GFR discussed in CKD? The reason is GFR becomes useless in AKI because when the patient presented to you, the GFR that you draw when you draw kidney function, you draw blood and then you measure GFR, that was the GFR of a sick patient. Does that make sense? Hello?
Yes. Yeah.
Yes, it makes sense.
All right. So
Yeah.
so again, GFR is glomerular filtration rate. So the normal is about 60 mLs per minute. Okay. So that's how fast your kidneys. No, 50, 60. Yeah. So that's the how fast your glomeruli are filtering your blood.
Professor, this book says the GFR is 125 ml per minute.
Oh yeah, I said per hour.
Oh, okay.
Different. There's different numbers, but let's say 60 is our, which is for most textbooks we use 60 as the lower limit. So in a patient with AKI, when we draw the GFR, it's already the GFR of a patient with a kidney injury. Whereas if you draw GFR in CKD, the patient when they visit you, they're not in acute kidney injury, meaning whatever GFR they have there, that is the GFR baseline. And then now you have a basis for comparison. If that GFR gradually decreases from several months to several years, and then you have some comparison, that makes GFR very reliable. So it became useless in AKI. That's why in acute kidney injury, the only thing we can use as the kidney function to assess the kidney function is only the BUN creatinine. You have no choice because again the GFR there is not reliable anymore because the patient is already in kidney injury. So in CKD you can compare GFRs, so that's how we stage them. So in stage 1 they may still be um, at 60, okay, and then or a little bit less, and then it goes lower from there. Look at this now in ESRD. The GFR is only 15 at that point. So imagine a patient in CKD, what they will look like if you read all these symptoms here, which is also presented in table 62.4. What does this remind you of? What phase in AKI?
Oliguric
Um,
phase.
In the oliguric.
yeah.
Yeah, so it's easy to see. These patients in CKD, they are permanently in the oliguric phase with no chance of recovery. Meaning, unlike AKI, wherein you have a chance to recover, correct? As long as you progress from the oliguric phase to the diuretic phase, and then you'll recover. CKD has no such chance. Once the damage, let's say they reach already stage 5, which is now 15 mLs per minute, they will be permanently here. There's just no chance. Again, the only cure is, of course, you get a new kidney. Well, not technically new, but like new, a recycled kidney from somebody else. So a transplant. So it always has slow, okay? So slow increases or gradual increases, whereas in acute kidney injury, this thing, like what happened to Davian, it all occurred rapidly. Within a few hours, you went from being a healthy person to now in acute kidney injury. Any questions so far? All right, let's go now to figure 62-4. So this will explain most of the paragraphs that you see. I personally prefer tables if you haven't noticed already. So figures and tables are easier to study because they tell a story. Okay, so look at this for instance. Look at the things that will go wrong. So this takes us back to what are the functions of the kidney. So we said those two kidneys maintain electrolyte and fluid balance, right? So these functions, are these still existing in CKD?
Yeah, they would be still
But are
functioning
they
in
at
CKD.
normal levels though?
No, they're not at normal levels, but they
And
slowly
then
getting there.
right, so again, the severity depends on what stage are you at CKD. So the patient has a chance to maintain it, but never to improve. Okay, because once kidney damage has already been done, it's gone. Okay, so the patient's kidneys can only do so much now. So that's why we have the stages. So let's say at stage two, this is all stage two CKD kidneys can do. All right. So that's that the severity of these problems that result, let's say for the anemia, for instance, will depend on what stage is the patient at. And until we get to dialysis, which is now stage five, of course, these are all totally gone. It's like the kidneys are still there, but they're just there. Okay,
But hold
they
on,
yes, sir.
sorry. I have a question. So if it gets to, let's say, stage two, it can never go back to stage one.
No, no.
Oh, it could just be
It's like
maintained at
saying
stage.
you lost. Yeah, it's like saying you lost your finger, right? Will it grow
Mm-hmm.
back?
Okay, no.
No, that's gone. Unlike because the kidneys don't regenerate. The liver has a chance to regenerate. Kidneys don't.
Okay.
Okay. That's why you can donate the liver. Okay, you can be a living donor for liver because it can regenerate to some
Mm,
extent as long as you're a healthy person. But of course, if you have cirrhosis, a cirrhotic liver can't regenerate, so you can't donate that liver.
yeah.
Okay. So the diagnostic, this is again based on GFR. We just draw blood and we make the doctor makes a diagnosis, okay, both in your GFR, the BUN. Treatment is all supportive, um, unless you're lucky to get a transplant. So treatment will be basically replacing kidney function, which is done through dialysis. But if as long as you're not in stage five yet or late stage four, all we can do is just maintain it. Avoid, remember what we did toward the end of AKI, wherein we maintained so much um, protein intake, for instance, avoid nephrotoxic agents.
Yeah.
Yeah, those things you can do just to prevent you from progressing through the stages of CKD, meaning avoiding pre-renal, intrarenal, and post-renal causes of kidney injury. So you can still do that just to maintain you at your current stage. But once you're already in the advanced stages of CKD, then you need interventions in order to replace kidney functions because there's no way you can continue to survive without the kidneys. So here comes renal replacement therapy. So that's the um, broad term for dialysis because we have different types of dialysis. So they fall under renal replacement therapies. So these are your findings. They're again permanently in the oliguric phase. So here you have the anemia. So think of this as the numerical representation of figure 62.4. So now the patient in CKD has no kidney function or very little, if any. So we have permanent hyperkalemia, permanent hypertension, Yeah, that because the kidney's already gone. Hypocalcemia, hyperparathyroidism, anemia, dyslipidemia, and so on. Please read on your own because they mention the management here, which you already enumerated for me anyway earlier during the first hour. So that's how you manage your hypertension. And we had an extensive safety alert box earlier, again, before the break, about management of potassium. So these patients will be on Kxalate every day now. They do have to watch for diarrhea. That means they've taken too much of the Kxalate already. So that might cause dehydration. So that will be a cue for them that they've been taking too much Kxalate already. We'll look at the medications later. You'll see K-Phos is one of the, or Foslo will be given to these patients. Those are a combination of calcium and phosphorus supplements that they'll have to take daily. For those of you who had a chance to go to the hospital, have you ever had a dialysis patient in the actual hospital or the nursing home?
Yeah.
How many medications were there on the MAR?
There were about
20, right?
yeah, there were a lot. It was a
Yeah.
lot.
So,
I think the first patient you gave me had like 35 medications.
Yeah, it was
oh yeah, I remember I had you guys in Woodhall.
You made me write everyone down.
yeah. We had
Yeah,
to
so
write them
you can
down on the
see, yeah, most of them were hypertensive medications, right?
yeah.
And
Right.
then we had a lot of supplements. We had renal gel, we had Foslo, um, right? And then there were also they had resins also, like the SPS. They received Kxalate on a regular basis,
Yeah.
and
Yeah.
they had plus they also had medications for the underlying cause that led to the CKD in the first place. So most of those patients were also diabetic, right? They were also obese. So on top of the medications for the kidneys, or as a result of the CKD, they also had the medications for the risk factors that led to the CKD. So that at least takes you to 20 medications at least. And that was just during your shift because all we had access, remember, we didn't have access to the MAR. We only had access to the active medications during the day shift. So that wasn't even it yet. And you saw the diet, I'm sure that it was controlled. They had so many grams of protein and so many grams of sodium and potassium. We will not talk about transplant yet. We'll cover that under another module under immunity as a whole. And then we'll come back to chapter 62 for the exemplar. Okay, but not during this semester. Just an FYI, nice to know. So this is how they do kidney transplant now. Used to be in the 70s, 80s, they took out the old kidneys, and then the modern approach now is to leave them. So just put the new kidney here and attach it to the iliac. So they leave the renal arteries alone. Because the problem they've always encountered during the um, old-fashioned approach was when they cut these, the patient ends up really um, like almost hemorrhaging. Okay, because these are large arteries. Look at the aorta alone is the size of your arm, and so you can imagine how big these renal arteries are. So they stop that practice. So they just use the patient's, the donor, the graft's own renal arteries and attach them to the iliac. So that was the safer approach. So that's where they put them now. So they put them in the pocket because this is your pelvis here. This is your pelvic bone, and they just insert it there.
Professor, what do they do with your old ureter then? Like, do they clamp it off or something?
Clamp what off? This one,
The
the
yeah, the
no,
ureter.
they leave them
Yeah.
absolutely alone. They leave them alone
Oh.
because they're technically not dead. I mean, they're alive. They're just not functioning. So nothing, no, doesn't harm you. So just leave them there.
Oh.
Complications is related to. Never mind. I'll discuss rejection um, in another module. And that's the end of CKD. Any questions? Okay, let's go to dialysis next. It's in a different topic. All right, so this is RRT. There are different types. We have hemodialysis, which is the most common. Then we have peritoneal dialysis, which is still surprisingly still on your NCLEX test plan. If you download the NCLEX test plan, they still mention peritoneal dialysis. Why? I really don't know, because not too many people are using it. And then we have the CRRT, which is the third. It's still a type of hemodialysis, but this one is slow. Okay, this one is done in the ICU only, as far as I know. At least the last time I practiced, the CRRTs are only done in the ICU because these are done on unstable patients. Patients who cannot tolerate large amounts of fluid removal, meaning they are not hemodynamically stable. They are probably patients in shock or let's say COVID-19. Okay, so COVID-19 patients, and then they went into kidney failure, for instance. They experienced, I don't know, a septic shock maybe, and then lost their kidneys and now are on dialysis. So since they're not hemodynamically stable, they can't undergo regular hemodialysis. So they'll do CRRTs. So the way CRRT works is it's like hemodialysis over 23 hours. Okay, really slow, like only a few mLs per minute of exchange. So the body hardly notices that blood left the body. Okay, so it's good for those unstable patients, but takes really long. I mean, it's practically the whole day, 23 hours. Hemodialysis lasts only 4 hours typically. For those of you here who work in dialysis, so about 4 hours, and they remove up to anywhere between 2 to 4 liters of fluid each session, and that's done 3 days a week typically, or maybe 4 days sometimes, depending on the patient's blood work. And they also have home dialysis now. um, I don't know what those machines are called, but they can do daily dialysis now at home. But because they're smaller fluid removal, so they have to do them every day, as opposed to large volume removals, which are done three times a week. So when is dialysis indicated? So this will answer the question. A patient will need dialysis when which of the following are present. Select all that apply. And there's your answer. So how does dialysis work? Well, it mimics the kidney as close as possible anyways, but we can't really replicate it the way it exactly works. So we have an artificial kidney in the dialysis machine. So they use a few modes of fluid transport, namely ultrafiltration and also osmosis. So they use the dialysate fluid in order to accomplish these movements. So we'll watch a video, which is easier. Can you see the video?
No.
No?
No.
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 Now?
Yeah.
Yes.
We can't hear it though.
What was that, sir?
I said we can't hear it. We could only see it, but we can't hear it.
Let me turn on closed caption.
Professor, I can't hear it.
But can you read the closed caption?
Okay.
Okay. I encourage you to watch that video. The video was from Nucleus Media. It's free. So just type in hemodialysis animation and that should pop up as a choice. So let's describe what we saw on the video. So hemodialysis is the most popular. We use, before we can do this though, you need an access, meaning we need to remove your blood, put it into a dialyzer machine, and then return it to you. So a vascular access site is necessary to do that. The fastest way to start, as you saw in acute kidney injury, was, since it was one of the options, so we can do a dialysis catheter. A dialysis catheter can be non-tunneled or tunneled. The difference between the two is a non-tunneled is shorter. It's about maybe 8 inches long, sometimes 6 inches long. So it's a temporary, obviously, because it's not designed for long term because it's short. The tunneled one can last longer because what they do is tunnel. Let me show you on the 1393. Okay, although this one is a central line, but it's the same concept. So this is a non-tunneled one. Okay, it's shorter. And this is a tunneled catheter. So same concept, they put it in a big vein. They can also put it in the femoral artery, which is another option, but isn't really the best because the groin isn't easy to keep clean. No, it's dark, moist, and warm. So your catheters tends to be can get infected more frequently if you use the femoral. So the most commonly used are either the jugular here on your neck or the subclavian over your upper chest. So they can do the left or right. So if it's a non-tunnel, the catheter will come out here. This catheter, unlike this one, this is very long. So a non-tunneled is shorter, meaning they inserted it straight right here. So the doctor will fish for the subclavian artery. No, subclavian vein, sorry. So they'll put the catheter straight through here and then it stops right there. So they can use it for dialysis. It's short term because they easily get infected because the access site is also the insertion site. Meaning if this insertion site gets infected, then you can guarantee the catheter is already infected. Unlike a tunneled catheter, so there are two incisions made here. One here, which is several inches away from the insertion site. So they tunneled it here. So this is called the exit site. This is the exit site of the catheter. So this is only done in the OR. The non-tunneled catheter can be done at the bedside. A tunneled one is done in the OR because they have to do two incisions. One here to insert the catheter underneath the skin. Technically, it's underneath the subcutaneous layer. So they tunnel the catheter here and then put another incision. Now this second incision is now where the catheter enters the subclavian vein. So what you'll see is only this one here, the exit site, okay, not the insertion site. So therefore, if you get infection here on the exit site, it stays local because it doesn't enter the the vessel until here, because this is now closed. This incision is closed, so is this one, but you won't see any opening here. You'll see as what used to be a stitch, but you can feel this section right here. The tunneled section, the tunnel section, this can be felt from the patient's skin. So you can see, oh, you can clearly see, oh, the patient has a tunneled catheter. Okay, so this is what you access. So it becomes long term. You can use it indefinitely as long as it stays infection free. Are you okay with that so far? So that's the fastest way. However, the problem with catheters, whether it's tunneled or non-tunneled, is infection. Usually it's from the user. The user gets careless, doesn't follow proper aseptic technique, and now the access gets infected. And we can't leave it, so we have to take it out because otherwise the patient may go into sepsis. So that's the downside there. So the preferred access site is to create a fistula. A fistula, by definition, is an abnormal connection between two normally non-connecting parts of a body. So is it normal to see a artery and a vein connected? Is that normal?
No.
No,
I don't
because
think
an
so.
artery ends in a capillary, right? And then from
Yeah.
that capillary, it goes on to the vein. So technically, an artery and a vein never connected. They're, you can say if it's a train, they're connecting um, section is the capillary. Okay, so but you'll never see an artery and a vein connected. So when they create an abnormal connection between an artery and a vein, as you saw in the video, they surgically stitch them together. It becomes a fistula. A fistula, though, will take maybe up to 2 years in order to mature, because you have to wait until it becomes stable. Meaning you technically created a new vessel there, right? It grows because is the vein built to withstand the pressures that an artery is subjected to?
No.
No, there's no pressure at all on the vein side. So veins normally have thinner walls compared to an artery. Arteries have thicker walls because that's what they're built for. They can withstand high blood pressures. Veins can't. So the vessel, when you put them together, of course, the side on the vein will tend to enlarge in order to compensate for the increased pressure. So normally you'll see AV fistulas easily because when you palpate the patient's arm, you feel the large vessel underneath. Okay, so they typically grow. I've never seen a pretty fistula. They all look ugly because they get deformed, right? Plus, it's not normal that you have something sticking underneath your arm, but that's what happens when you have a fistula. A graft is an artificial connection, meaning they don't surgically connect the artery and the vein, but instead they use a plastic catheter to connect an artery and a vein. So it's an artificial connection. Okay, it's not a fistula. Between a graft and a fistula, you can of course use the graft right away, but they don't last very long. So the fistula is the preferred access sites because it's your own vessel. They they are long lasting. Okay, they're permanent. Okay, you can use them almost forever.
Can you have more than one fistula?
I have seen patients, yes, because their fistula got damaged, um, which is rare, and the doctor had to create a new one. And some of them also, unfortunately, do not mature. Okay, because it's not always successful. They never mature and can never be used. Okay, which is unfortunate. So until the fistula matures, we have to use another alternate way to perform dialysis. It's usually a catheter. But believe me, if the nurse is careless, the patient, especially if it's a younger patient, as long as they're well educated, they will be the ones actually intimidating the nurses. Okay, they'll check out the dialysis nurse if they know what they're doing, and then they'll literally stop them if they miss a step, because the patient, of course, has a higher stake at this. It's their life that they're talking about here. They need that access for to survive, and if they see somebody who doesn't give a S word, you know what I mean? They'll tell that nurse. Okay, they're very aggressive when it comes to their fistulas. So you saw the video. Preparation is the patient's medications will have to be held for the day, because it doesn't make sense you give them medications and then they will be dialyzed. Okay, they will be removed by the machine. Plus, especially antihypertensive medications are not given because we're removing a lot of fluids here. So number one side effect after the procedure is hypotension. So we'll only see after dialysis if their blood pressure remains high, then they'll get their antihypertensive medications. But most of the time they don't need them, because because of the rapid and volume of removal. Also, usually they remain hypotensive the rest of the day. So you saw the video. So we put two needles in, one takes it out, the other one returns it. So they stay in the, if you guys ever donated platelets or plasma at a blood center, that's half the time they spend. So I'm a regular platelet donor. I stay there 2 hours. So these patients will be there for at least 4, and that's 3 times a week. At least sometimes they do a fourth day. So the machine basically is the kidney now. Some of the medications used, we use heparin in the circuit. When they say circuit, that's the tubing. In order, because the blood left your body, so it can clot. Okay, because it's no longer inside you. So to prevent it from clotting, so the surface of the tubing has heparin in it. And there's saline also in the circuit. So here it is. This is the demonstration of a hemodialysis. The question isn't really about how the machine works. It's about what is your responsibility if the patient is going to through hemodialysis. So we described the pre-procedure. So your number one procedure is to hold the medications for the day, and then assess when they return to the floor whether or not it's safe to administer those medications. Here are the complications. All of them are testable. Please read each one. Like I already said, hypotension is the most common, because you try losing up to 4 liters of fluid from you at one time. So imagine pooping 4 liters of fluid out. Let's see if you don't get dizzy or lightheaded. Others are related to the substances that are removed. These are common because of the electrolyte changes, because there are electrolytes that are also removed during dialysis. So it depends. Muscle cramps, usually that's from either potassium or calcium removal. Bleeding is also common, especially if you have a fistula. Infection, although infection is less now, unless I mean, as long as you're with a experienced nurse, in a dialysis center, those guys are pretty good. They know what they're doing. That's the one job they do every single day, 7 days a week. No, 5 times a week. So they become experts at these. But the book is still required to put these. These are the possible risks associated with hemodialysis because you get frequent punctures. Now imagine needle sticks every 3 times a week. These are all long ago. Okay, long ago, yeah, we had Hep B, C, HIV infections associated with dialysis. It's almost unheard of today. This is rare. You can skip this one. This one, though, is quite common. Okay, this is again related to the fluid shifting during the procedure. And regarding the access site, yeah, it can cause bleeding also, especially if there's not enough pressure applied after the needle access is removed. They can also clot, which, if not addressed, may lead to damage to the fistula. Then we can't use it anymore. And that's it. Any question on hemodialysis? So what do we not do to a fistula? The arm that has the fistula.
Take a blood pressure.
You
All
don't
right,
take blood pressure.
do not use that arm for anything. No blood pressures, no needle sticks, no IV insertions. Okay, definitely not. The patient's life depends on that access site, so do not mess with that arm. CRRT is done through a central line. We don't need a fistula for this one. Like I said, this is temporary. This is done in ICU in unstable patients who cannot tolerate large volume removals. Peritoneal, this is done at home. As you saw on the video, well, it's not the arm, it's the peritoneum. Where's the picture? Right here. So this is peritoneal dialysis. So basically, they use the peritoneum as the semi-permeable membrane. So they need to insert a catheter. So this is done at home. Of course, there are complications here. You have an access site, so this can also get infected. But again, the patients are aware of the complications, so they make sure they really wash their hands before they handle the procedure, because this is done by the patient themselves. It may sound simple on the video you saw, which was they only demonstrated one exchange. So there are 3 parts to this. One is the inflow. The second stage is dwell time. And then the third stage is outflow. Again, an exchange is one peritoneal dialysis session. One exchange is composed of 3 stages. First is inflow. That's when you hang the bag of dialysate. The bag is about 2 liters at least. So that's a big bag. So they connect it to the catheter, and then it takes 10 minutes to infuse. So the inflow is 10 minutes. The dwell time takes about 2 hours. So after 10 minutes, they disconnect the bag, and then they're free to move around. So they walk around the house, do errands, they can go to the grocery, whatever they want to do. They come back 2 hours later. This is now the third stage. They now do the outflow. Outflow, they drain the fluid out. So they connect another bag to drain the fluid. This bag now that is drained typically is your urine. What does urine contain? BUN, creatinine, what else? Everything that's supposed to be filtered by the kidney. Okay, so I call this urine because it's basically it. So this is the dialysate fluid and then comes out. Of course, it also contains some of the most of the dialysate fluid. But the one thing to note is you can't use the same bag because for one thing, are you draining less or more fluid?
Less fluid.
If
More.
you say less, meaning you put in 2 liters and you say you're gonna drain out 1 liter,
I think it should be more.
it should be more because this is dialysis. You're trying to remove excess water, excess electrolytes, and waste products. This is dialysis. So you're supposed to remove more because you have to take this bag out. All the fluid that you put in there must come out along with the excess fluid and the waste products and the excess electrolytes. Okay? Now, so that is one exchange. So therefore, if this is 10 minutes, and then 2 hours, how long does one exchange occur? I'll take.
2 hours and 20 minutes.
So about 3 hours. Okay, let's just say
We
three
are.
hours. The patient has to do 5 to 6 exchanges in a day.
Wow.
So how many times do they have to do it?
Three
At
times.
least 5 times a day. Now you have 24 hours a day. You have to sleep some of that time. So imagine what the patient will do all day. This is pretty much all they do. So after one is done, they get ready for the next one. And then once that second one is done, they get ready for the third one. Once the third one's done, they get ready for the fourth one, and so on. So this is the patient's life
How many times a week do they have to do it?
every single day.
Wow.
This one is different. Okay.
Yeah, 5 to 6 times a day, 7 days a week.
So their whole life is just based on this now.
Yeah, basically it. Yes.
Wow.
So what lesson have you learned here?
Make sure you don't get to this point.
Yep. Protect your kidneys. This is something the patients must understand. They may say, because they won't see it. I mean, they'll never comprehend unless they actually see what a person has to go through. This may look, worse than a hemodialysis, but look at the patient with hemodialysis also. Patient with hemodialysis has to contend with this 3 times a week also. Imagine sitting there 3 days a week, or sometimes 4, and this is also for the rest of your life. And then we have storms. So let's say we get a winter storm, then you have to go to the center in the middle of a blizzard. Because if you don't go, then you don't get the dialysis for that day. Right? And then we have COVID-19. Right? And then you need this. You need this every single week. Some
So
may ask,
Professor,
so yes, sir.
is it not better just to change the kidney instead of letting the patients go through all this?
Easier said than done, sir. How many kidney transplants have you heard of happening every day?
They have a list.
The problem is the matching of the donor. That's the problem. Most rich people get it,
because they have money.
Yeah, because of course they say no. Oh, we're on the list, but oh wow, all of a sudden you're on the list. Like
Yeah.
um, yeah, and then how many people are waiting and then die because they never got a match? Are you saying just these rich people were lucky?
When
Anyway,
they
that's
it,
politics.
Yeah.
Okay, so let's do the complications now. So we did the hemodialysis complications are the bleeding, infection. Okay, let's look at the complications here. Before that, let's do contraindications first. So they cannot do peritoneal dialysis because we looked at there was a list here also like this for the hemodialysis, right? So this one is the contraindication. So if a patient chooses peritoneal dialysis, they can't have it if they have these. The back pain here or the vertebral, spine problems come in because imagine carrying 2 liters of fluid about 5 to 6 times a day. That's a lot of weight to carry, right? So that puts strain on your back. And these are the others because imagine again putting in 2 liters of fluid there and carrying it for 2 hours. So if you have hernias, so that's a contraindication, or COPD because put 2 liters of fluid in your abdomen. Will that not put pressure against your diaphragm?
Yeah.
Yeah, so COPD patients, they need that chest expansion. You can't have chest expansion if you're pushing against a full peritoneum, a full abdominal cavity. Complications similar to hemodialysis because they can also have bleeding. First is catheter infection and worse, peritonitis. Now, this is usually from contamination of the access site. Abdominal pain because of you're using your abdomen, particularly the peritoneum, as the um, semi-permeable membrane. So here are the reasons. The catheter might injure the organs underneath, or they can even puncture a bowel. Um, please read hyperglycemia, outflow problems. Sometimes, just like what we mentioned earlier, sometimes you get less fluid out. So these are the possible problems that can lead to that. We don't want that happening. So make sure usually we ask the patient to just reposition, change your position so that maybe the catheter was kinked or maybe the fluids are trapped in pockets in between organs. It can also cause constipation. And as already mentioned, it presses against the diaphragm, so you may have respiratory problems. Protein loss, unlike in hemodialysis, wherein protein you don't lose as much protein because the peritoneum is a more permeable membrane compared to the dialyzing membrane in the dialyzer. Patients typically lose more protein in peritoneal dialysis. So, do you think they will receive protein restriction?
No.
No. This is the only thing different. If a patient is using peritoneal dialysis, there is no protein restriction. They're allowed as much protein as they want. Some dialysis centers also give their patients protein bars during dialysis because it's also possible during hemodialysis. Again, the testable part of dialysis is making sure the patient stays safe. So questions would be on what are your contraindications, complications for both hemodialysis and peritoneal dialysis. We can also have, oh, by the way, the peritoneal dialysis, there's also something called um, automated, this one, APD. This one 8 to 10 hours only. So the patient goes to work, comes home at night, When they go get ready to go to bed, they connect their catheter to the machine, and then the machine does the exchanges for them. So no manual hanging of the bag, none of that. And they don't have to do it 5 to 6 times a day. They just do it during their sleep. Okay, that's an option.
How how come they don't do that? How come they don't do that option regularly? Like that seems better than doing it all day.
Simple answer: insurance.
Oh,
Yeah.
so I guess like as you were saying, rich people could probably do that then. That
Yes.
one, the automated one.
Yep.
Uh,
Well, not necessarily rich. I mean, it's really depending on what insurance. But I see what you mean. I mean, rich people tend to get better insurance,
yeah, better
but not
insurance.
all the time. I mean, if you have a good, company, they take care of you. Yeah, some like
True.
take a look at government, for instance. Yeah, those politicians, the government insurance is pretty good.
Yeah,
Yeah, but not all government positions necessarily pay higher.
the best. Yeah.
Okay, so please again, the questions would be on the complications. Okay, they're pretty self-explanatory. Let's discuss this one briefly. The peritoneal dialysis part, make sure the dialysate is assessed. So, what do you think is wrong if the dialysate is cloudy?
Infection?
Okay,
No,
just
you
like
drop.
UT, yeah, just like a UTI, right? Your urine is cloudy, so that's a sign of infection. What if it's red,
Bleeding?
bleeding? You may have perforated your, you may have injured the bowels. What if it looks brown?
Mm, um,
Bun?
Feces.
The bun is
Remember, the
leaking. I don't know.
catheter is in your abdomen,
on
and
is
it's a long, rigid catheter.
long
I mean, it's
time.
soft, but
It's
is
in
that
there.
could that be poop?
Yeah, feces.
Yeah, it may be feces. You may have punctured the bowel. Okay, so you teach the patient there to assess what does the dialysis look like, the outflow. Okay, what does the outflow look like? Make sure it's clear.
It's
Okay.
clear.
Yellowish color, that's fine because it's supposed to look like that. Clear or slightly yellowish, that's fine because you are removing waste products. As long as it's clear though. Cloudy, it's not supposed to be cloudy. Your urine's not supposed to be cloudy, right? Alrighty, let's see if we've finished. 11:40. Yeah, that's it. Any questions on